topic which was for Dr. JASPREET SUKHIJA, intraocular lens implantation in children, when and where to place. Dr. Savleen is presenting because Dr. JASPREET could not come because he was hospitalized.
Thank you, sir. So after those wonderful videos, we'll just describe one or two different sites of intraocular lens implantation that we can keep in mind when we are dealing with such complex cases. So we have discussed that the indications of intraocular lens implantation are axial length more than 17 mm, a corneal diameter more than 10, in age more than 6 months, as given by the infant aphakia treatment study. There is no consensus on younger children, and of course we do keep into consideration the fact that we are dealing with a completely demographically different population than the West. So the intraocular lens implantation by convention is endocapsular, that is in the bag implantation, and the other techniques that we can do in certain difficult scenarios that we come across could be an optic capture, which can be done anteriorly, that is the bag is the IOL is in the bag and the haptics in the sulcus, or it can be done posteriorly, that is the optic is behind the posterior capsulotomy. We can choose the sulcus implantation in selected cases, and of course Mary Hoyt-Exignan has described the bag in the lens technique that can also be done. So a routine pediatric cataract surgery, we have seen the steps, that is it includes a complete lens aspiration after a good anterior capsulorhexis, a primary posterior capsulotomy, anterior vitrectomy, and an intraocular lens implantation in the bag. So once you have fashioned an anterior capsulorhexis, you do a irrigation aspiration of the cortex, then you implant the IOL after inflating the bag with a viscoelastic. So you can do a posterior capsulorhexis either before intraocular lens implantation or after intraocular lens implantation. Manual posterior continuous curvilinear capsulorhexis before intraocular lens implantation is the preferred and the better technique if you have the expertise to do that. Here we are using triamcinolone to stain the vitreous and then do a limited anterior vitrectomy. After you have done the anterior vitrectomy, you see that the margins of the posterior capsulorhexis are no longer rolled. That will tell you that the adequate vitrectomy has been done. And then again you fill the bag with a high viscosity viscoelastic substance, and you implant the IOL, the optic and the haptic both going between the margins of the anterior and the posterior capsulorhexis. That is the endocapsular or the in the bag implantation of the IOL. As we discussed that even after doing a good surgery, including a anterior posterior capsulorhexis and an anterior vitrectomy with an in the bag intraocular lens implantation, you do see a 17 to 20% chance of posterior capsular opacification also. So the there has been a lot of no consensus on actually whether you can do a posterior optic capture without vitrectomy to implant the IOL. We did publish a paper in the Indian Journal of Ophthalmology. So this is a posterior optic capture. In this, you'll implant the IOL behind the posterior capsulorhexis. The idea is that you do not do an anterior vitrectomy. You just push the vitreous back and you put the IOL in the Burgess space. That is the more physiological space for the intraocular lens. So I would just skip the few steps because we have already seen that you have dilated the pupil by an intracameral So you have dilated the pupil intracamerally by using phenocaine. So, and you have done, somehow the video is not playing. Is it? Okay. So you have done an irrigation aspiration, and then you inflate the bag by the ophthalmic viscosurgical device. You fashion a posterior capsulotomy in the same way that you did when you are planning an in the bag intraocular lens. Should I wait?
There is still time. There is still time for completion of the session. This is the last presentation.
I can just switch to the video. Okay, I'll just play the video from here. ये presentation चला दूँ दोबारा? Wait. I just have to forward it. Okay, so you have fashioned a posterior capsular axis, and now you'll implant the IOL. You have a prefixed, preloaded IOL or a 3-piece IOL, whatever IOL you do, you implant the optic in the bag and then you dial it completely. After you have implanted it, you push the optics of the IOL behind the posterior capsular axis or capsulotomy that you have made. So you see you've pushed one haptic and the other, and you see this elliptical shaped posterior capsular axis because of the optic that is behind the capsule. So the optic is pushed back, the haptics are in the bag, and this is a posterior button holding or posterior optic capture of the IOL. So you're not doing a vitrectomy here because there are certain proponents of vitrectomy, and there are people who say that vitrectomy in a growing eye can have negative effects including retinal complications. So by this technique you avoid doing a vitrectomy and you are still obtaining a clear visual axis. The paper that I was citing, we compared intraocular lens implantation in the bag in one eye and posterior optic capture in the same patient in the other eye. So you are doing away with the patient factors, and we saw that you do have some lens epithelial cell proliferation that you see in the bag IOLs, but a posterior optic capture gave a clearer axis. Of course, the rates were comparable. So it's not a superior, but it's an equivalent technique to an endocapsular implantation of IOL. There are scenarios where you would want to do an anterior optic capture also, like the one that I'm showing. Again, we published this cataract surgery in children with buophthalmos, a series of patients where you have implanted the IOL anteriorly and captured it anteriorly. So this is a buophthalmic eye, again fraught with certain complications. You're doing an anterior capsular axis. Now, if you implant intraocular lens in the bag in these eye, the IOL tends to wander because it's a bigger eye and you're putting a normal sized intraocular lens. So either you have to fix this IOL somehow. So you are fixing it anteriorly. So you again dial it in the bag and then the optic is captured in the anterior capsular axis. So this is anteriorly captured. So the IOL is relatively stable. This elliptical margin that you're seeing is now the anterior capsule. So to conclude, primary intraocular lens implantation is a good option when you are doing a pediatric cataract surgery, and it's a clean cut case. And primary intraocular lens implantation is of course avoided in certain cases, but when you are choosing for an intraocular lens implantation, conventional placement is in the bag, can have certain issues of visual axis opacification and glaucoma. So you can refine your technique by choosing an anterior and posterior optic capture, of course with the adequate surgical expertise. The interior optic capture is a good technique for buophthalmic eyes, and bag in the lens is also a promising technique if we have that in, because of its limited availability in India.